Morning, everybody. It's welcome to Medicine Grand Rounds. It's my pleasure to introduce this year's annual Guller Lecture. Just a word about the Guller Lecture. This is a lecture that was supported by Cindy and Keith Guller, who, as they do every year, are here today. I'd like to recognize them for supporting this lecture. Cindy and Keith both have had their brush with either cardiovascular risk or cardiovascular disease, and decided that they wanted to give back with an educational series about prevention of cardiovascular disease. And this has been a recurring theme throughout all these lectures on different aspects and perspectives on cardiovascular prevention. So this year, I'm very pleased to announce and present the Guller Lecture, Dr. Chiadi Ndumele. Dr. Ndumele is the Director of Obesity and Cardiometabolic Research and Director of Heart Failure Prevention, and Associate Professor in the Division of Cardiology at Johns Hopkins. Now, Dr. Ndumele, his training pedigree is impeccable. He received his MD from Harvard, did his internal medicine at Brigham and Women's Hospital, and then was chief resident, and then trained in cardiology at Johns Hopkins, where he was also a chief cardiology fellow, and he also received his MHS and PhD in epidemiology. He's a leader in preventive cardiology, and his focus in research is characterizing the relationship of obesity and cardiometabolic risk factors to the development of disease. He's been a key leader in the revision of cardiovascular risk prediction models, including the recent PREVENT calculator, which not only incorporated our traditional risk factors that we use in the pooled cohort equations, but incorporated measures of metabolic health and renal health. And he has received multiple recognitions. He is chair of the Council on Lifestyle and Cardiometabolic Health at the AHA. He's chair of the AHA Cardiovascular-Kidney-Metabolic CKM Health Initiative. And in 2024, he was awarded the AHA Award for Meritorious Achievement. So we're very, very pleased to welcome him to WashU as this year's Guller Lecturer. He's going to speak to us today about the cardiovascular kidney metabolic syndrome. Jeremy.
Here you go. No problem. Thank you so much for the very, very kind introduction, and it's really quite an honor to be here today. Thank you again to the Guller family for so generously supporting this education around cardiovascular prevention, and thanks to all of you for being here. So I do not have any personal disclosures. This is the disclosure for Medicine Grand Rounds. And here are the objectives. So the objectives here are that by the end of this talk, you'll be able to describe the rationale and definition for this construct of cardiovascular kidney metabolic health, or CKM health. I'm going to spend most of the time focusing on the key steps for applying the CKM syndrome care model in clinical practice. And at the end, I'll speak a little bit about, and hopefully we'll be able to all describe next steps in the implementation of CKM syndrome care. In 2023, there were two major papers put out by the American Heart Association, a presidential advisory, and also a scientific statement on the concept of CKM health. So, and that's obviously generated a good amount of discussion. And the big question is, what is that, and what is CKM syndrome, and why should you care about it? So first, let's talk about the definition and its importance. So CKM really is this health disorder that reflects the connections among heart disease, kidney disease, diabetes, and obesity, and that leads to poor health outcomes. The reason for this is because these conditions have such tightly intertwined pathophysiology. Additionally, because over the last 3 decades we've seen such growth in rates of obesity and diabetes, CKM syndrome is now really becoming the predominant phenotype of cardiovascular disease risk in the population. And it has multi-system consequences, but the most substantial consequence is premature mortality, primarily of cardiovascular etiology. So there's a lot of public health urgency around this challenge. But now we have some growing scientific understanding and multiple new therapeutic strategies that substantially improve outcomes among individuals with CKM syndrome. Now, the story starts from adiposity and obesity being a key driver of inflammation and insulin resistance. And we know that it used to be thought of as just a storage depot, but now we realize it's so metabolically active with the release of cytokines and adipokines and potentiation of acute phase reactants. And a lot of that's due to ectopic fat within the visceral cavity, liver, and skeletal muscle. This causes inflammation and then also insulin resistance that eventually, with beta cell dysfunction, leads to hyperglycemia. And this is the reason why we have these twin obesity and diabetes epidemics. So wherever we see obesity using these CDC maps, that's where diabetes soon follows. But the picture has become increasingly complicated over time, and it really has changed our overall phenotype of cardiovascular disease risk. So this is basically what we call a hierarchical clustering map, and you can look here and see this is 1990, this is going out to around 2015. The clustering is supposed to reflect what is the primary kind of phenotype or etiology for your cardiovascular disease risk. And you can see here the purple and you can see the blue, and that's hypercholesterolemia and hypertension. And if you look over time, you can see the proportion of individuals for whom that's isolated hypertension, hypercholesterolemia, the primary cause of their cardiovascular risk has declined steadily over time. And that contrasts with what we see in the orange, which is obesity, and the light blue, which is chronic kidney disease, where you can see the proportion of individuals for whom that's the predominant phenotype of cardiovascular risk has increased over time, and a steady burden of severe hyperglycemia. So all in all, over the past 25 years or so, more of obesity, CKD, hyperglycemia, and less of just the traditional hypertension and hypercholesterolemia, although those are still present and complicating the challenge. And this really is because of this conceptual framework where these are all closely interconnected. Again, starting with excess and dysfunctional adipose tissue, and particularly what is potentiated by ectopic fat deposition, including the liver, inflammation, oxidative stress, vascular dysfunction, and are all the kind of consequences which lead to the development of metabolic risk factors, development of chronic kidney disease, and altogether contribute to the development of all forms of cardiovascular disease, and also potentiate those very challenging, clinically challenging heart-kidney interactions that we know of as cardiorenal syndrome. So this interconnection is why we need to think of these less as separate issues and more as an interconnected whole. Now, we mentioned that at the end of the day, premature mortality is the principal clinical consequence, and that's true for the individual components of this. So severe obesity, we see an 8 to 10-year survival reduction, diabetes, 13 to 14-year survival reduction, and chronic kidney disease, stage 4, about a 20-year, greater than 20-year survival reduction. However, because of this interconnectedness, we don't usually see these in isolation, and that really means that basically that confluence, when we see them coming together, actually leads to synergistic increases in mortality risk. So this is a nationwide sample, 10-year mortality risk. You see diabetes, 11%, CKD, 17%, but greater than 30% when you bring together diabetes and CKD. And we see this more and more with this confluence of factors. This has also contributed, very importantly, to a change in cardiovascular disease mortality that's really made itself most clear over the last decade. Basically, over 5 decades, we've had continuous declines in cardiovascular disease mortality. Smoking campaigns, knowing about cholesterol and blood pressure, better cardiovascular procedures, and all of a sudden, in the last decade, we've seen a full plateau. And in the last couple of years, seen an uptick in cardiovascular mortality. And this is widely believed to be related to the emergence of obesity, diabetes, and CKD and the relevant sequelae. When we have patients who have multi-system challenges, fragmented care is often a challenge because of that. They're seeing multiple different providers. The patient with diabetes and CKD and heart failure, for example, seeing a primary care, cardiologist, nephrologist, endocrinologist, and probably some other individuals in the care team. Often what happens is that's challenging to navigate. They're getting different statements from different individuals. And because a lot of the therapies we're going to be thinking about have multi-system effects, who's in charge? It often falls through the cracks because of our siloed approach. Given CKM syndrome, there's a need to shift from a fragmented silo-based approach to a more patient-centered approach where we consider what the patient is actually seeing in terms of these interrelated conditions, as well as the need to focus on coordinated care and the underlying social context that contributes to so much of what we see. So we'll come back to this concept nearer to the end of the talk. An important concept with regards to thinking about holistic patient-centered care is social determinants of health. So we think about this often in a research capacity, but it's really important that we start to think about this in terms of our care approach and our care models. And the reason for this is because these impact the natural history of CKM syndrome. So certainly health behaviors, how we eat, how we sleep, how we stress, how we exercise are all directly impacted by social determinants. They also impact who develops these risk factors, and when the risk factors develop, are they identified in a timely manner? Additionally, in the context of these risk factors, it impacts self-care as well as engagement with the healthcare system, and through these and also direct mechanisms, directly impacts complications of CKM syndrome. So, in the context of CKM health, it really is important to think about this from a broader socio-ecological framework. So yes, individual predisposition matters, and there's all these different biological components that are quite important, but we need to think about that nested within this broader level of multi-level social determinants, and to consider social determinants in all aspects of CKM syndrome assessment and management. And I'll come back to this point as well near the end. I'll give you a quick insight into the process for this CKM syndrome process. So essentially, it involved kind of the AHA bringing together a very large multidisciplinary group, and I was privileged to be a co-chair for this, and then essentially to bring together this compendium and action plan that was represented in the papers I showed earlier. There were several consensus conferences with various stakeholders across disciplines, and now where we are is focusing on adoption and implementation. So this specific slide I'll come back to again at the end of the talk. So now that we have a sense of what CKM syndrome is and how its definition is, the question is, well, what is the optimal clinical approach to caring for individuals with CKM syndrome? So I will put the steps for applying the CKM syndrome care model into 5 buckets. So 1, systematic testing for CKM risk factors. 2, staging of CKM syndrome for qualitative assessment of cardiovascular risk and promoting prevention across the life course. 3 is quantitative assessment of cardiovascular disease risk with the PREVENT calculator that Samantha mentioned. 4 is personalizing the clinician-patient risk discussion. And then 5, I'll spend the most time on holistically addressing these CKM syndrome risk factors. So first, systematic testing. And the reason for those kind of routine assessments is because many of these conditions historically go long unrecognized and unaddressed, while they're still conferring quite a bit of risk. And we also know that when these risk factors develop, the timely initiation of therapy, including lifestyle modification, actually is associated with substantially improved clinical outcomes. So we think about this, and I'll go over the staging in a moment. In terms of the stages, as we get to higher stages and higher risk, there's a need for more intensified and more frequent screening, and you can see things kind of spread out as you get to later stages. And I want to also emphasize that in those with existing cardiovascular disease, there's also needs to be a focus on looking at these risk factors as part of optimizing secondary prevention to really improve overall therapeutic management. Among the risk factors that go long unaddressed and unrecognized is chronic kidney disease. So this is something that, especially for all of us, and certainly for the cardiovascular community, needs to be very much on our radar screen as an underrecognized cardiovascular risk factor, and a risk factor, as I've mentioned already, for mortality. There's a lot of opportunity because 90% of individuals who have this condition are unaware of their diagnosis using national data. And we now have so many cardio-kidney therapies with widespread benefits that makes this an urgent area of clinical focus. And you can see here the lower eGFR is associated with cardiovascular outcomes and all-cause mortality. However, there's a need to move beyond just using eGFR alone to also use urine albumin-to-creatinine ratio because, number one, they're both diagnostic part of the criteria for chronic kidney disease, having elevated albuminuria or having lower eGFR, but number two, they provide complementary risk information. They give information on 2 different axes, and the information is not just for kidney disease risk, but it's for cardiovascular disease risk and for all-cause mortality. So you can see here, this is urine albumin-to-creatinine ratio. Here are the typical GFR categories we're aware of. And you can see that as you get to these darker colors, especially the red, that's reflecting that higher and higher risk. And this is very high risk chronic kidney disease. Look at patients with eGFR in the 3A with 45 to 59. If you didn't look at UACR, you would miss that some individuals are moderate risk, some are high risk, and some are very high risk, just to illustrate the importance of that. And we focus on regular testing in those with diabetes, hypertension, and CKD because they actually have the highest prevalence of albuminuria. So this is an important paradigm change to focus on as part of cardiovascular disease assessment and prevention. An additional important piece that's very co-localized with CKM syndrome is metabolic-associated steatotic liver disease, or fatty liver disease. This is now, because of our emergence of CKM syndrome, the leading cause of cryptogenic cirrhosis and need for transplantation. And you can see this progression from healthy to fatty liver, MASLD, to steatohepatitis, and then to cirrhosis with the irreversibility. We want to get people before they get to that stage. We know there's a threefold higher risk among those individuals with overweight and obesity, and diabetes in particular, 70% have MASH. So they basically have that inflammatory component there. So really, we know that lifestyle change and weight loss can reduce fatty liver. We now know that GLP-1 receptor agonists can not only reduce fatty liver, but also reduce liver fibrosis based on the most recent Essence trial in the New England Journal. And we also have a tool to start detecting people in these early stages of liver fibrosis with the FIB-4 index. So basically, regular screening with that is now going to be a part of the guidance because using that index has a pretty good way of ruling out people with fibrosis. So essentially, if you have greater than 1.3 for 35 to 64, or greater than 2 for greater than 65, then you want to do more testing to look and definitively assess whether there's liver fibrosis. So these are key things that have not been on our radar screen that need to be part of our assessment approach. I don't quote Machiavelli in my daily life, but this quote I think is actually very apt in terms of CKM syndrome. The challenge of delayed recognition. At the beginning, a disease is easy to cure but difficult to diagnose. But as time passes, having not been recognized or treated at the outset, it becomes easy to diagnose, but difficult to cure. And this is, he was talking about political dysfunction using health as a metaphor, but I think this is very apt for CKM syndrome. We've all had those patients we see with diabetes and CKD and heart failure and all these other conditions, or ASCVD, and how challenging it is to keep them healthy and out of the hospital. So catching them early will really make our lives easier in this portion, and this is why we focus on the staging of CKM syndrome. It follows the typical pathophysiologic progression that I showed you in the conceptual framework earlier. So we should start with stage 0, which is not part of CKM syndrome. So individuals who are in an ideal cardiovascular health place, and we want to keep people there for as long as possible. Stage 1, the excess or dysfunctional adipose tissue, is the precursor to so much of this multi-system disarray that comes afterwards. Stage 2 being the emergence of metabolic risk factors or chronic kidney disease, or both. And then stage 3, where we start to see that subclinical cardiovascular disease or high-risk equivalents, like very high-risk chronic kidney disease or high predicted risk using the prevent risk calculator. And then stage 4 is clinical cardiovascular disease overlapping with metabolic risk factors or chronic kidney disease. So the goal is not to find a new, I mean, trust me, we have enough staging, but the goal is to really start to detect individuals earlier. We see people when they already come to us with diabetes and this and all these conditions, but what if we can get people earlier in the phase and not just detect risk, but prevent progression later on to the later stages of CKM syndrome? But when we do see people who are at that higher risk area, we want to intensify therapy appropriately to prevent that progression of cardiovascular disease. And an important public health message is that we can actually promote regression of CKM syndrome. We know that individuals with subclinical heart failure, metabolic risk factors, some aspects of CKD, obesity, we can actually go in the right direction with substantial lifestyle change and weight loss. So that's an important key public health message as well. This is data from the ARIC study just showing CKM stages and essentially different forms of cardiovascular disease. All forms of cardiovascular disease are substantially increased as you go into higher CKM stages, as well as cardiovascular mortality. But I do want to point out heart failure, because heart failure has a particularly unique and potent relationship with CKM syndrome. You can see here that if you take these risk associations, relative risk associations, and prevalence, and use that to calculate a population attributable fraction, 80% of heart failure may be attributable to CKM syndrome. So a very potent risk relationship, and this is likely responsible for a very important epidemiologic change over the last decade. So heart failure mortality had been dropping, but in the last starting around 2012, we've seen it go completely in the opposite direction, an increase in heart failure mortality that's in contrast to dropping rates of coronary heart disease mortality. This is likely related to HFpEF, heart failure with preserved ejection fraction, going up, and a result of aging and CKM syndrome. Exacerbating this in the context of heart failure is when we see the intersection of these CKM risk factors. So diabetes, chronic kidney disease, and heart failure is a tremendously important kind of clinical entity and public health entity. And we see a lot of clinical and epidemiologic overlap. You can see here, among heart failure patients, 42 to 50% have CKD. Among patients with heart failure, 25 to 40% have diabetes. 40% of those with diabetes have CKD, and 16% have the combination of all three. This is not just epidemiologic, it's actually pathophysiologic, because each of these conditions influences likelihood of the other conditions and increases likelihood of worse outcomes. So you see increase of mortality when diabetes is present, when CKD is present, and when you put diabetes and CKD together, not only heart failure hospitalizations and cardiovascular disease, but also all-cause mortality and non-cardiovascular hospitalizations as well. So an important entity to be aware of in terms of something we need to be addressing as part of this model. I want to talk a little bit about PREVENT, which was basically resulted from the fact that as we were seeing this recognition of CKM syndrome, it was clear we needed an updated approach to prediction that reflected the needs of this population with CKM syndrome. And the key updates here are that we've moved beyond just atherosclerotic cardiovascular disease to now look at heart failure as an outcome, as well as total cardiovascular disease, heart failure plus ASCVD. Expanded the age range to start at age 30 rather than 40 because of the earlier presentations we're seeing. And then for younger adults, looking not only at 10-year risk, but also 30-year risk, because that time horizon more adequately reflects their overall risk characterization. Several CKM syndrome components in the model, and we're seeing improved calibration across demographic groups. And this is thought is going to be important for not just statins now, but for thinking about non-statin pharmacotherapies. So conceptualizing predicted risk, here's the importance. So essentially, if you have a therapy that has a given relative risk reduction, let's say 25% relative risk reduction, it's those individuals who have a higher baseline starting risk that are going to get the greater absolute risk reduction, and that's reflected here. So you can see this is low risk, intermediate risk, high risk, same relative risk reduction, but because of where these individuals are starting, their absolute risk reduction, how much their absolute rates will come down is much more substantial. So those individuals, we do that, you're going to get more clinical utility, a lower number needed to treat to prevent events, and greater cost effectiveness. So that's the rationale for focusing on this kind of risk-based approach to thinking about prevention. We've seen this being helpful in diabetes. This is work from the TIMI trial from David Berg that basically took individuals in an SGLT2 trial, or two SGLT trials, and basically put them into different risk categories: low risk, intermediate risk, high risk, very high risk. You could see across these different groups, the relative risk association, the hazard ratio, is pretty similar, 0.6 something, 0.7 something, similar relative risk reduction. However, the absolute risk reduction, the number needed to treat, is much different. So you can see here in the low risk, 303 people needed to treat to prevent a cardiovascular event, as opposed to in the very high risk, 36 people needed to treat to prevent a cardiovascular event. So a very substantial difference, and really reflects the importance of thinking about this in this population. PREVENT is probably just going to be a starting point as we think about this. There's also going to be additions that will help, and I think in the context of heart failure, we have data now saying that the kind of pre-heart failure assessments give complementary information to PREVENT. So this is looking at the ROC curves for PREVENT in blue, but when you add pre-heart failure measures of cardiac biomarkers or cardiac biomarkers plus echocardiogram, you see enhanced overall risk discrimination. But on top of that, if you look at individuals' absolute risk in this heat map, so this is the PREVENT risk categories. This here is the degree of pre-heart failure, normal, abnormal biomarkers, abnormal echo, or abnormal echo and biomarkers. You could see that here, those individuals who have higher PREVENT and have abnormal biomarkers or echo, base and echo, have substantially increased heart failure risk. And you could see prioritizing therapy and optimizing our targeting for this high-risk population. So an important thing to think about, given how important heart failure is going to be in the context of CKM syndrome. I also want to focus on the concept of CKM stage progression. So if you watch most people over time, this is from the ERIC study, looking at 8,000 people followed over about 9 years. This is a Sankey plot that shows about 40% progress to higher rates. So most of the lines are going to the next stage, looking from the baseline to the next 9 years. But that, even though the CKM stages are so substantially associated with outcomes, it's really the progression of CKM syndrome over time that's associated with the greatest impact on all-cause mortality. So you can see these are the stages, the orange being people who progress, substantially higher all-cause mortality, which is largely driven by cardiovascular disease mortality. So impacting that progression, stopping that progression is really a key focus area. As we think about progression, that's where the concept of CKM risk enhancers come into play, because these are factors that are associated with the likelihood or a greater likelihood of progressing along these CKM syndrome stages. Chronic inflammatory conditions, more adverse social determinants of health, certain demographics like being from South Asian ancestry, mental health and sleep disorders, certain sex-specific risk enhancing factors like preeclampsia or other adverse pregnancy outcomes, C-reactive protein or family history. These are things that can be used to personalize discussions when you're thinking, okay, I have all these therapeutic options, who am I going to prioritize because I'm worried about their risk of progression and higher risk for mortality and cardiovascular events. So this is something that is helpful as a tool in personalizing those discussions with patients. Now, I'm going to spend most of my focus here on thinking about the approach clinically to addressing kind of mitigating risk in CKM syndrome. And I think the important take-home is that we historically have thought about this in terms of, hey, I see some hypertension, hey, I see some blood pressure. And we need to recognize that it's not going to be sufficient in our current era to focus just on individual risk factors alone for optimally preventing heart and kidney disease. And these multiple interrelated conditions have to be thought of and addressed holistically. These are going to be the top therapeutic priorities in the context of CKM syndrome. So addressing obesity through the multiple modalities, using cardioprotective glucose-lowering therapies in diabetes. Blood pressure control is always going to be a mainstay. Using kidney protective agents to prevent kidney and cardiovascular events, and then also lipid-lowering therapy that's according to individuals' cardiovascular disease risk. So I'll go through these, some of these in a bit more detail. One is addressing obesity. The reason I'm going to say this is because this is not something we do well as a community. This is not something we're trained to do well as a community. And because of how our society is structured, there's quite a bit of judgment, stigma, and bias that goes around discussions around weight in this population, where there's a lot of thoughts about personal responsibility rather than the systemic issues and the biological issues that contribute. What we do know is that when we take a judgmental approach to weight loss discussions, it's far less effective at achieving clinically significant weight loss than taking a non-judgmental approach. And basically, this is from what's called the Stop Obesity Alliance's toolkit and gives us a framework that we promote for addressing conversations with obesity: the ask, assess, advise, agree, assist, arrange, and a very non-judgmental approach. So that's an important initial piece to consider that really we need to all work on. When we do get into the weight loss discussion, we now have an array of weight management options. So lifestyle modification we know to be effective for inducing modest weight loss. And we know that when we do have that modest weight loss, we see improvement in several CKM risk factors, the diabetes, the lipids, and the blood pressure in particular. However, we do not see a reduction in cardiovascular disease events in randomized trials. We do know that metabolic and bariatric surgery has a much more potent impact on weight. It's the most potent weight loss therapy that we have, and in matched non-randomized studies has a dramatic impact not only on cardiovascular disease events, but also on all-cause mortality. But historically, that's led to a bit of what Dr. Lingvay has called an obesity treatment gap, where on one side we have lifestyle and these kind of older pharmacotherapies where you have this modest weight loss, and then on the other side we have this invasive procedures in bariatric surgery where we have much more dramatic weight loss. But what about in the middle for a large portion of the population who are less interested in that kind of invasive approach? And this is where this newer pharmacotherapies come into play, the GLP-1s, the GLP-GIPs, and then soon the triple G agonists and others in obesity. So these have dramatic impact. So in patients without cardiovascular disease, we now know with semaglutide and tirzepatide about 15 to 20% reductions in weight, and also, particularly when lifestyle changes are incorporated with that. We also know, unfortunately, just like most other medications, that when we discontinue those medications, the weight and all the metabolic risk factors go right back in the other direction. We know there's improved metabolic risk factors, and we also know improved quality of life. We've had some pretty landmark trials over the last few years in the context of patients with cardiovascular disease, where we also see the weight and metabolic benefits, but the landmark SELECT trials, shown at the top there, show that in patients with overweight, obesity, and ASCVD, we saw a 20% reduction in major adverse cardiovascular events. And a good amount of that, as I'll talk about in a moment, was weight loss independent. In HFpEF, we see the SUMMIT trial, where the combination with tirzepatide is associated with not just improved quality of life, but a 38% risk reduction in reducing heart failure events. So, as a result, these need to be part of the weight management discussion and primary prevention, but first-line considerations in patients who have ASCVD or heart failure with preserved ejection fraction for secondary prevention. Another area is chronic kidney disease. So chronic kidney disease, we know now that we have several therapies that directly impact reducing progression of chronic kidney disease to kidney failure. We know that ACE inhibitors and ARBs have some efficacy, but now recent medications include SGLT2 inhibitors, non-steroidal mineralocorticoid receptor agonist finerenone, and GLP-1 receptor agonist semaglutide, which all reduce kidney stuff, but also have a dramatic impact on cardiovascular events, and particularly on heart failure. You can see the risk reductions shown here. So these are agents with dual benefits from the standpoint of kidney and cardiovascular benefit. So this has led to this concept of thinking about these different pillars of therapy we talked about last night for type 2 diabetes and chronic kidney disease. And there's going to be some thought about how we apply this. I don't think this is going to actually be the same as HFrEF, where we're giving everybody every medication. But it's important to know that we have multiple agents that improve both kidney outcomes and cardiovascular outcomes in the specifically that DKD, diabetic kidney disease population that's so high risk. And I do think that this actually represents a very important frontier for us in cardiovascular disease prevention, because we have a very high prevalence of unrecognized disease, as I mentioned in the beginning. We have a very high absolute cardiovascular disease risk for these individuals, and now we have multiple risk-reducing therapies, so I think that that represents substantial unrealized potential for population cardiovascular health. So an important next frontier in cardiovascular prevention. The next area is diabetes and CKM syndrome. There are 4 key elements there. One is healthy lifestyle modification as a foundation, which really addresses a lot of the underpinnings of the metabolic disarray that contribute to this. Number 2 is collective risk factor control. 3 is lipid-lowering therapies, statins being the mainstream, but then, as I'll talk about, other therapies potentially being adjunctive and being beneficial, and then using these cardioprotective glucose-lowering therapies in those who are higher risk. I often get asked from people who are like overseas or in resource-limited areas, what about if we don't have all these fancy medications in this context? What do we do? And I think it's a very relevant question, but it's important to recognize that there's data from before we had all the fancy medications, and the STENO-2 trial is a great example of that. That's a very CKM population, patients with type 2 diabetes, overweight, obesity, and albuminuria, and basically it said, hey, lifestyle modification versus using usual care versus using lifestyle modification with adjunctive pharmacotherapy as needed to reach glycemic, lipid, and blood pressure goals. Over about a decade, almost a 50% reduction in mortality, almost a 60% reduction in cardiovascular disease events. And this is before all of the fancy therapies, this interdisciplinary multimodality risk factor control. So just recognize that we don't need to do all the fancy stuff to achieve benefits in these patients with multimorbidity. Now, in terms of the newer therapies in diabetes, these are by clinical trials. We have data that these are prioritizing these as therapeutic options in diabetes, SGLT2 inhibitors or GLP-1 receptor agonists. And the SGLT2 inhibitors, we know they reduce major adverse cardiovascular events and CVD mortality, not huge glycemic benefits, but dramatic improvement in heart failure hospitalizations and kidney events. GLP-1s, we've talked about some, MACE, cardiovascular mortality, marked weight loss reduction, and not just the glycemia events that are very substantial and metabolic risk, they also improve fatty liver, as I've talked about, and MASH, and also now most recently we've seen in diabetic kidney disease improving kidney events and mortality in diabetic kidney disease. When we're using these 2 agents in diabetes, you can think, hey, if I have a patient with CKD or pre-heart failure, prevalent heart failure, I might prioritize SGLT2 inhibitor. In severe obesity, very significant hyperglycemia or MSLD, I might prioritize GLP-1 as a starting point, but certainly for individuals who have more of these conditions or who are more advanced in disease, using combination therapy is certainly going to be an option as well. I want to say a little bit more about GLP-1s because I think they're going to be a very important therapy moving forward over the next decade or so, or 2 decades. We've talked about them in terms of diabetes and weight, but it's important to recognize that there's some very significant weight-independent benefits of these agents. So in the SELECT trial, the big trial on obesity and ASCVD, we saw cardiovascular risk reduction well before there was substantial weight loss. And the cardiovascular benefits achieved were actually independent of the degree of weight loss. This is the Harmony Outcomes trials, not talked about very much anymore because it's a drug that we don't use anymore, albiglutide, one of the GLP-1s, that didn't actually have much of an impact on weight, as you can see here, but despite no impact on weight, still had that about a 22% cardiovascular disease risk reduction. So there's a weight-independent impact of these agents, which actually raises some important questions, as I'll say in a moment. But as you look at our conceptual framework for CKM syndrome, you can think about GLP-1s as really fundamentally impacting much of this physiology, impacting weight, impacting fatty liver disease and ectopic fat, impacting the inflammation and insulin resistance and oxidative stress and probably vascular dysfunction, metabolic risk factors, chronic kidney disease, and both directly and indirectly impacting cardiovascular disease outcomes. So fantastically interesting therapies. But of course, we have a public health challenge with these therapies because if you look at the epidemiology of CKM syndrome, about 90% of individuals are falling somewhere in this stage 1 to 4 population, and most have some indication that you can find for GLP-1 therapy, whether it's overweight, obesity, or diabetes, or with or without concomitant CKD, ASCVD, or HFpEF. If we gave things to everybody who could apply for one, it would far eclipse gross domestic product. Okay? So this is not actually going to be something we can medicalize to the population. So how do we prioritize the utilization of these therapies? I suspect that the 2 things that we're going to be able to think about are going to be the degree of multimorbidity and also the degree of short-term cardiovascular disease risk. These clusters of multimorbidity tend to come together, and we all have this indications for GLP-1s for all these therapies, obesity and HFpEF, obesity, diabetes, ASCVD, diabetes and CKD, particularly with higher risk CKD. It's likely that we can achieve more multi-system benefit if we're starting to think about targeting these clusters as much as possible of individuals with these overlapping multi-comorbid conditions. The other concept is short-term risk. We talked about this in the context of PREVENT. Another way of looking at absolute risk is, like, for example, coronary artery calcification. So if you look at coronary artery calcification and a modeling exercise with GLP-1s, this is individuals who have no CAC. You can see the number needed to treat about 280. People who have modest CAC of 1 to 100, you can see here it's 145, and it gets down to 85 if you get to CAC that's greater than 100. And it goes up, of course, if you go even higher in terms of CAC. So you get a lower number needed to treat by treating higher risk groups. And this is really very kind of congruent with this concept of using a predicted risk of some way to identify those high risk populations. So I think that these are good and important, thoughtful processes, but here's the challenge. So when we have substantial multimorbidity and high short-term risk, you could put those 2 together, it's a no-brainer. You see that person in front of you? Obviously, you should be thinking about treating them with something like a GLP-1. But what about when you have patients who have high cardiovascular risk, but they don't have all that multimorbidity? Is that still a place where it makes a lot of sense? And these are often going to be isolated risk factors among older adults or people who have mostly non-CKM risk factors like smoking or hypercholesterolemia. How do we conceptualize things there? But I think even more challenging is when we have substantial multimorbidity, but we don't have a high 10-year risk. We have a low 10-year risk, but a high 30-year risk. So those younger adults. And we know that stopping these therapies is going to be challenging, so how do we conceptualize things there? And I think that that's going to be one of the key study questions we need to contend with moving forward as we think about allocating these therapies in the population. There are many, many, many unanswered questions around GLP-1s. They have heterogeneous effects. We think we know a little bit about that, but we don't fully understand. When we don't have any weight loss, do we still have CKM benefits, and how much? We have a lot of discontinuation, 50% at 1 year among individuals with obesity without diabetes. What's the real-world impact of that in terms of what we're seeing in terms of benefits? Compounded formulations rose up in the all the supply chain disruptions we had. So now there's all these places that are giving these out off-label, not FDA approved. Do those have similar effectiveness or safety? What about the long-term weight loss maintenance and the weight loss quality in terms of muscle loss and bone loss? And then the multi-system and off-target effects of these agents, and we need more mechanistic insight. So recognizing this, the AHA has actually started a new a longitudinal study called Healthy Living Beyond Weight, which I'm the PI, that is basically, I'm laughing because there's a lot to do. But it's basically a large registry study that's going to follow these individuals longitudinally to give more insight about not only the impacts of overweight and obesity from a CKM standpoint, but also the impacts of these novel weight management therapies, combining like direct to participant survey and EMR-based approaches, and also increasing levels of deep phenotyping to give us more insight into the impact of these therapies and the lived experience of individuals with overweight and obesity. I don't want to forget about LDL, which is a fundamental part of so much of what we thought about prevention for several decades. And it is also impacted by CKM syndrome. So when we have patients with ASCVD, multiple CKM risk factors, diabetes, hypertension, CKD, that actually fulfills criteria. I was part of the 2018 cholesterol guidelines for that concept of very high risk ASCVD, because those are independent risk factors for adverse outcomes, and because the data from Improve It, the study of ezetimibe in patients with ezetimibe added to statins, show that add-on therapies may be particularly beneficial for high-risk patients, where we actually see a greater absolute risk reduction as expected, but also a greater relative risk reduction. So this concept of very high-risk ASCVD, when you see that patient with CKM syndrome and ASCVD, you should think, ooh, this may be a very high-risk ASCVD patient where I want to be more aggressive in terms of lipid-lowering therapy. The other thing has come up recently is actually from the Vesalius trial by my colleague Aaron Bahula at the Brigham Women's Hospital, that looked at the concept of aggressive prevention for these individuals who haven't had a stroke or an MI, but have high-risk diabetes or have qualifying atherosclerosis like CAC, or have had a revascularization or have non-obstructive disease. What about if we do more intensive therapy for them? And those people, almost 70% were on high-intensity statin. They used PCSK9s and showed they brought the LDL down to 45 compared to about 110 in the controls, and had a 25% decrease in major adverse cardiovascular events. This has basically led to the concept of, for these CKM stage 3 kind of populations, do we need to be more aggressive in terms of thinking about care? So now I want to think about the care model as part of the final component of this, and that's really this concept of patient-centered approaches and bringing together these individuals from different silos to address what the patient is seeing. And a key element of this is using interdisciplinary care approaches with the help of what's called a CKM coordinator. And the goal is to support patient education and activation, to support better GDMT utilization, to support care coordination, and to also provide social support as needed for individuals with adverse social determinants of health. We know that there's increasing data supporting this. Actually, the STENO2 trial was a coordinated care model approach, but we know that this is effective both in person and virtually for improving holistic care. This is a cluster randomized trial called Coordinate, led by my colleague Neha Pajadipati at Duke, that basically showed that using this coordinated care approach, what they call this CKM coordinator and implementation specialist, led to a 4-fold increase in the use of multiple kind of major therapies of preventive therapies for patients with diabetes. So we know that this approach for complicated patients can be really helpful for getting to goal for what we need to do from a process standpoint. We talk about these complementary interdisciplinary care models, and basically we talk about one kind of remote approach where basically it's being supported for patients who have this confluence of risk factors with an interdisciplinary team with representation from primary care and subspecialists, and the CKM coordinator partnering with PCPs and supporting patients in the journey to optimizing health. But then also for those higher risk patients, a volume-based approach where we're basically targeting referrals to subspecialists and then having the coordinator assist with the navigation across multiple subspecialists. And there's a recognition that across the country, there's some places with more density of subspecialists and less density, so you need flexibility to use telemedicine and rely on one or the other approach more as needed, and also flexibility to not just hire new CKM coordinators, but also to repurpose the existing staff like diabetes coordinators and heart failure coordinators who are already seeing these patients to play this role in terms of supporting holistic and patient-centered care. And then I want to emphasize the importance of social determinants, and this is going to be a key portion of the model. So not just a systematically screening for social determinants using validated tools, but also The prevent prediction model now includes a measure of social determinants in their social deprivation index, but we want to integrate these into our clinical care workflow and have individuals on the care team, social workers, community health workers, care navigators, who can help address these as they're identified, leveraging community resources and programs. And I'll speak more about this at the very end in terms of what's happening with implementation. So here are the key highlights of the care model for CKM stage 1 to 3. When we have confluent risk factors, interdisciplinary care, and addressing social determinants, really focusing on controlling CKM risk factors holistically, addressing obesity through multiple modalities, and then that comorbidity-based approach to selecting cardioprotective antihyperglycemic agents, and then preventing CKD progression is a key target for not just improving kidney outcomes, but cardiovascular outcomes. And then finally, more intensive and combination therapy in higher risk patients. And then stage 4 is similar, just a higher risk population that inherently already has comorbid conditions that need to be addressed with interdisciplinary care, addressing social determinants, thinking about obesity and ASCVD, and heart failure with preserved ejection fraction, and pharmacotherapy being a frontline consideration there. And then, of course, controlling CKM risk factors. Everybody who has diabetes and CVD should be on a cardioprotective antihyperglycemic agent, and then preventing CKD progression. These are all kind of the main highlights of the care model. As I mentioned, this is the kind of vision for CKM care, and the next steps are taking this and now adopting this and implementing this more broadly in the population. The presidential advisory laid out a kind of 8-pillar framework for optimizing CKM health, considering social determinants more systematically, improving access to pharmacotherapies, addressing key research gaps, supporting interdisciplinary care, supporting CKM education, enhancing our obesity management, implementation within and across health centers, and supporting healthy lifestyle communities. Each of these are their own talk. And there's actually work going on in all of these areas through the AHA and various partners presently, but I will speak more on the concept of implementation within and across health centers. First, I will emphasize that a lot of what I'm telling you about is actually being, well, I can't say what's being incorporated. I could just say that there are going to be AHA, ACC, CKM syndrome guidelines released early this year that's been announced by the AHA to ACC. And of course, this will be a really key step for not only giving concrete guidance, but also supporting billing and quality measures related to CKM syndrome care. So this is kind of on the horizon. The other thing I want to mention is a nationwide initiative, the CKM Health Initiative, a 4-year initiative that's just started this past year, and it's ramping up. It's across 15 markets, 150 sites, over 265,000 patients, and really taking a lot of what I just told you about and applying that to actual communities and health systems to improve CKM syndrome care, which will then be leveraged across the broader network of hospitals within the AHA network. These are the initial 15 markets that are included in the CKM Health Initiative, representing a cross-section of the country and also CKM Health in the population. And here's this approach. So it's really the primary goal is to improve this adherence to evidence-based care measures over baseline for patients along the spectrum of CKM syndrome, and of course then secondarily to improve outcomes. It involves adopting this interdisciplinary care model, incorporating SDOH into the care model, including what we call clinical community linkages, and then also a campaign to activate individuals with CKM syndrome in their health by basically a consumer activation campaign. And it also involves a collaboration with the National Center for Quality Assurance to harmonize metrics around CKM syndrome care and quality as part of this work moving forward. So, in summary, the concept of CKM health reflects the fact that we have this interplay among metabolic risk factors, chronic kidney disease, and the cardiovascular system that is increasingly relevant to how we should be conceptualizing cardiovascular risk. We need holistic care approaches to mitigate this multi-system morbidity and the greater risk for mortality that's inherent to CKM syndrome. So as I've mentioned, optimal CKM syndrome care is really 5 steps. Systematic testing for detection of CKM risk factors in a timely fashion, qualitative risk assessments using that CKM staging approach, which is all about not just meeting patients at the end stages, but try to prevent at the earlier stages progression along that natural history of CKM syndrome. Complementary quantitative risk assessments, which are imagined to be helpful for our approach to thinking about allocating therapies, personalizing risk discussions with those CKM risk enhancers, and then finally, holistically addressing those interrelated CKM risk factors in the context of interdisciplinary care models that can make, hopefully, all of our lives, and more importantly, patients' lives and outcomes better. thank you. It's really a privilege to be here. Thank you to the Guller family for your amazing support. I'm supposed to show this slide as well, and I'm happy to take questions.
Thank you, Chiadi, for that just fascinating presentation. I'm going to open it up for questions. Farhan?
Wonderful presentation. Great overview of what we do every day from a prevention cardiovascular standpoint. I saw a lot in the prevent score. I didn't see anything mentioned for the calcium scoring or imaging. How are you incorporating that in the guidelines and statements, especially given the decades of data showing prognostic discrimination calcium scores, and more recently with total plaque volume plaque analysis coming forward?
That's a good question. I'll repeat the question. So it's a question of how are we incorporating CAC scores, which have quite a bit of data in terms of risk and also in terms of characterization and in terms of improving allocation of therapies into this. And actually this weekend, I'm going to be doing a debate about prevent versus CAC scores, and I'm actually arguing for CAC. So that's my assigned role. But essentially, yeah, so I think they're actually complementary. So I think that essentially, historically at least, CAC has been most helpful for those individuals who are in the intermediate risk in terms of their kind of initial predicted risk. Not just in terms of targeting where we're more likely to see something that might be abnormal, but also in terms of where we're going to get the most potent up-risking or de-risking in terms of kind of overall health, and they're very potent from that standpoint. I also think that there's more data showing that CAC is probably going to be, the degree of CAC and the degree of plaque is going to be helpful for talking about the intensity of our preventive approaches, and not just for statins, but for also therapies as well. So it's part of stage 3. It's an important concept. Using it judiciously in the context of the right population, I think could be a very helpful adjunctive tool.
Mark?
And what it requires physician specialists, for example, so that the fourth one, for example, like how much do you think that can be done by non-physicians, for example?
Yeah, so I think it's a great, so good question is how much can be done by AI? And there's a lot of interest in this area in terms of these 5 steps for optimizing CKM syndrome care. I think that there's a lot that AI and EMR-based approaches, data approaches can actually do to help with regards to automating kind of this staging kind of characterization, automating kind of the prevent, and then also kind of highlighting key risk enhancers that are present for individuals to be able to pay attention to. I think the other piece that is potentially helpful is to kind of give a frontline, you know, here are some things that might be considerations based on the profile of this individual in front of you, with the room to have autonomy and kind of shared decision-making, but here's the pieces in front of you. So I actually think that that's actually going to be a really important next step to think about for this. And actually, I know there's a lot of thoughts and work starting to go into this space already. So I do think it's an important adjunct, particularly given the complexity of what we're facing, to try to make it as simple as possible for clinicians and actually be an adjunct to what we do.
Other questions? Karen? Oh, sorry.
One of the things we've noticed in the heart failure space is this tendency to push guidelines on populations that have never been studied in clinical trials. I'm referring mainly to the elderly.
Oh.
What do you know about these risk factors and the age populations for which you do have data and you don't have data? Because sometimes it's really hard to push all these drugs, heart failure drugs, on grandma, you know, who's 92,
Yeah.
really can't walk and doesn't tolerate all the medicine. So are there age restrictions on these guidelines, or do we not know?
Yeah, so it's a great question. And basically the question is, how do we address elderly populations where we may have more limited data on our age? Are there age restrictions to these guidelines? So for most of these trials, for some of these trials, there were age restrictions. Most of them weren't actually age restrictions. They just didn't include that many populations that were older. There's a few of these where we do have, for some of these preventive therapies, blood pressure being probably the best example, but some of the diabetes, but more of that, where we have, and some cholesterol, where we have basically some elderly populations and some data on risk. I do think that as we're thinking about polypharmacy, as we're thinking about the other concept that I didn't mention of competing risk, of kind of the other things that could be occurring, we do need that's an important consideration in shared decision-making, but it's also a bit of a gap area because these populations, that elderly population, are the ones that we're seeing having a lot of that HFpEF. There's a lot of redistribution of fat to the visceral cavity that occurs with aging, even in the absence of a growth in waist circumference that really fuels some of this pathology. So I do think there's a need to address this population and a need to support this population, but we do need more data, particularly with regards to implementing this in these older populations to know what's feasible and also acceptable to patients.
Karen?
We're all asking totally unworthy questions. So, given that in our current healthcare system, we're totally willing to pay however many tens of thousands of dollars to put a valve in someone, but not necessarily to do any of the things that are on your screen, how do we make the policy and public health argument to change how we think about it?
Yeah, so I think this is a great, so the question is basically, given that we usually spend a lot more money on interventions than we do on prevention, how do we move this into the sphere? So I will say to your question, Karen, that actually the primary reason why I've dedicated so much of my life to this over the last few years is because of that, actually specifically because of the potential to use this to shape some parts of the landscape. I'll tell you that there's a few different things that I think can help align around this. Number one, there is more and more conceptualization of the healthcare costs downstream of obesity and all of its consequences. And that's in the order of trillions, and people are seeing that, and it's not getting less, and there's an interest in saying, okay, what can we do from that standpoint? And even the ICER, as they're starting to conceptualize the benefits, they're now thinking, well, it's not just the short term, let's think about all of these aspects. So I think that that paradigm change is helpful. Number two, I think that the way AHA operates with regards to these pieces, so we've kind of, the stick for, the carrot for getting everybody involved is to say, hey, you put these forward, they're gonna make this now part of branding for certifications, part of branding for center of excellence. And if you're not doing some of these things that we're talking about, these key parts of the care model, then you won't be a center of excellence. So you won't have the certification in CKM Health, which is increasingly a central part of how we think about prevention and management. I think partnership with the NCQA is really important as well, because while the AHA does more carrot work, they don't do the punitive stuff, but NCQA can help from the other side of this as well. And then I think the other thing that will be very helpful, and we'll see where this all goes, but the more that there's kind of unity across not just one group, but the multiple stakeholder groups in this regard, who are all agreeing that this is something that is central to how we need to be conceptualizing this, and we're speaking with one voice, I think the better. And I think there's a lot of efforts going on that way as well. So there's a lot of work to be done, but I think there's multiple arguments to make more of an investment in this aspect of this paradigm for health.
Okay, well, it is the top of the hour, so I think we'll stop here. If you have questions, please come down and talk to Chiadi. Thanks again for just an outstanding presentation.
Thank you so much. Sure. Yeah, it's a very interesting question. So essentially, the way epidemiologically, when you look at kind of discrimination doesn't change very much when you add CRP. However, it is something that among people who don't have traditional risk factors in particular, or even if they do have risk factors, it's associated with increased risk. The question that comes to play is basically on an epidemiologic kind of prediction scale, is that actually captured in the fact that they have all these, so because the information often acts